very difficult, and this is when you base more of your urgency of referral. So it's not a diagnosis, history, and examination, because all you're going to end up with is non-specific back pain. As I said, all that is undiagnosed back pain. So it'll help you. More importantly, you're excluding red flags, psychological problems, or your yellow flags. And at the bottom there, you're working out an urgency of treatment and referral. Does this patient need to be seen today, next week, a surgeon, a pain specialist, or a physiotherapist or physical therapist? So if we look at the neck, we'll work our way down. I'm not going to talk about the neurosurgical, so occiput, because that's a whole different approach and very little degenerative problems there. It's normally all secondary. So once again, history examination, you're working out, is this axial mechanical pain or is this a neurological problem? Combination of both, excluding the red flags. Does it need to be seen today, or does this need to be seen in the next few days, weeks? Surgeon, physiotherapist, and that's what you're doing. And then you're working out, once again, whether the problem is a cord problem or a nerve problem or an axial problem. And in the spine, it's the same as we use the term, and everyone knows, cord equine in the lower spine. For us in the upper spine or thoracic spine, cord compression is synonymous. So it's axial, radicular, but add on cord compression, because that in the LB is something that's often missed, especially if you've got Parkinson's and other medical conditions. So we'll look at simple pathology first. So a disc protrusion, we all see them, they present with neck pain, arm pain. Now if it doesn't get better, you go through all the treatment processes, they see a pain specialist. And for me, once again, most of these patients will go to a physiotherapist, will then have a foraminal injection pain specialist, and you'll hear all the different pain techniques. And very rarely would I operate in the first 3 to 6 months, because more than 80% are going to get better themselves. But if they don't, and this is what you've got, this is an operation that works extremely well for a disc protrusion. And so something we do, it's got 85 to 90% success rate, and the complications, although small, can be quite significant. So when I discuss this with the patient, and they're not getting better, for me, I lay the cards on the table, and I say, we can go back to try the physical therapy and the pain specialist, we can give it a bit of time, or if you've got a surgical option to this. It's your decision. And most patients, if they've come and they haven't been down that route of education, physio, injection therapy, will turn around and look at you and go, whoa, I'm not ready for surgery. And those that have been down, they'll say, right, when can I have my operation? And you can see it. And it's a realization